Well, thank you very much. I am currently the chairman of our orthopedic department here at the Summit Medical Group. I've been here about 15 years. Our orthopedic department has actually gotten very large over the past few years. We now have 13 orthopedists currently in 4 different offices. We cover the full gamut of orthopedic conditions, injuries, and illnesses. We also have 4 physiatrists. We have 5 physician's assistants, and we have a whole sort of separate spine program. We have a podiatry program. So we've really gotten quite a bit bigger. The trend over the past 10 years or so in orthopedics has been more and more specialization. My primary focus is on knee reconstruction and sports medicine. Most of my surgical procedures are knee surgeries. I do some hips, but primarily knees. And today I'm going to give a variation of a talk that I've given previously here at this sports fair, which is the arthritic knee and the weekend warrior. And this is really a topic that's become quite a bit of great interest in our community. So individuals in the United States remain healthy and active longer and participate in demanding athletic events and high-demand sports well into their 5th, 6th, and even 7th decades of life, which is increasing sort of by the year. And with this increased participation, there are more and more injuries, especially to the knee, which is vulnerable in many ways, which I'll get into a little later in the talk, which can lead to the early onset of arthritis and even severe arthritis at younger and younger ages, and increased incidences of arthritis in older people and people as we tend to age. It's clear from orthopedic literature that knee replacement surgery is very successful in elderly people and more sedentary people, relieving pain and restoring function. However, there's considerable controversy as to how best to manage the younger, healthier, more active individual who does develop arthritis, and especially advanced arthritis, at a younger age. So for the next 15 or 20 minutes, and I'll certainly leave time at the end to take questions, I'm going to discuss options for managing the arthritic knee in the younger patient, and I'm going to focus primarily on about a 40 to 60 year age group. So what is arthritis? People hear that term all the time. Arthritis is literally a wearing away of the joint cartilage. So our bones, really all the bones in our body, are coated with a smooth layer of white, shiny cartilage. It's called articular cartilage. And that is literally analogous to the cartilage on the end of a chicken bone. In any type of arthritis, that cartilage becomes worn down for whatever reason. Osteoarthritis is by far the most common type of arthritis, and most people, when they talk about arthritis, are referring to osteoarthritis. And osteoarthritis is literally a mechanical wearing away of that articular cartilage. Rheumatoid arthritis is probably the second most common type of arthritis. And rheumatoid arthritis, which I'm not going to get into during this talk, but is really more a systemic disease in which the body attacks its own joint cartilage. The knee, interestingly, is probably the most commonly involved joint in rheumatoid disease. Each type of arthritis has its own unique clinical and radiographic and even pathologic findings. What's characteristic of osteoarthritis is the edges of the bone become worn down and form these giant spurs, which are called osteophytes, which form along the rim of the bone. People can see them, feel them, and they're very visible on an X-ray. So osteoarthritis usually becomes a relatively obvious diagnosis in an examination and an X-ray. Over time, that cartilage becomes eroded, becomes uneven, becomes pitted, and that leads to pain. It's long been accepted by the orthopedic community that osteoarthritis is almost an inevitable part of the aging process. So everybody develops osteoarthritis in the knee to at least some degree. Each joint's unique. What's unique about knees is they do tend to wear down, and everyone does tend to develop some osteoarthritis at different ages and to different degrees. And with people living longer, people staying healthy longer, people staying active longer, and in addition to in conjunction with the aging of our population, the incidence of osteoarthritis of the knee is really rising exponentially over time. The main symptom is, of course, pain. Pain initially is felt primarily with movement and with activity, but over time, that individual can feel pain even at rest. The joints sort of feel stiff, they feel boggy, they feel swollen, they look swollen. They lose range of motion, both actively and passively. And that individual, over time, can develop difficulty with walking, maybe a limited walking distance, difficulty with stairs. People frequently report that they have to negotiate stairs one at a time with a banister. And over time, may develop difficulty with simple activities of daily living, dressing, tying their shoes. Causes wear and tear. It's sort of an aging type of thing, wear and tear over time. Injuries certainly contribute. There is a genetic component. It's not a one-to-one component, but clearly individuals whose parents have primary osteoarthritis of the knee are at some increased risk. Injuries to the knee, to the joint surfaces, either single traumatic events or repetitive cumulative injuries, cause problems over time. Obesity per se is not identified as an independent risk factor. However, that does lead to increased stress on a joint that may already be arthritic and can make the symptoms much worse. And certainly any deformity of a joint, either congenital or due to injuries over time, leads to increased incidence of osteoarthritis. Early on, there are frequently X-ray changes, but sometimes no symptoms. The Arthritis Foundation reports that most people over the age of 60 have at least some X-ray changes consistent with osteoarthritis, although only about 1 in 3 of those people have symptoms. The diagnosis is based on the symptoms and, of course, pain, careful exam, a series of orthopedic radiographs, which are weight-bearing radiographs of the knee, and we use digital radiographs here. Generally more sophisticated imaging modalities, MRIs, CAT scans, are not necessary for the routine diagnosis of osteoarthritis of the knee. As the disease progresses over time, the cartilage tends to wear away. This can lead the knee to become deformed. It usually wears away asymmetrically. The weight-bearing axis of the lower extremity goes through the inside or medial part of the knee. So very frequently, the inside part of the knee wears away more than the outside part, so that knee becomes bowed. The joint, of course, loses its normal shape and function. Osteophytes, which I mentioned before, are new bone or bone spurs that form along the ridges or the edges of the bone, and that bone and cartilage can break off and form loose bodies inside the joint. Treatment of the majority of orthopedic conditions is either non-operative or operative, and with osteoarthritis of the knee, like most orthopedic conditions, the treatment that should be initiated at the beginning at least is non-operative. The goals of any non-operative treatment for arthritis are to control symptoms, to help that individual stay healthy and active, and to delay any major surgical procedures. A couple of non-operative modalities that I'll mention briefly include exercises and physical therapy, bracing and orthotics, the non-steroidal anti-inflammatory medications, which are very popular, and injection therapy, both steroids and what are called injectable lubricants or viscose supplementation. Exercise is certainly one of the most effective treatment options for arthritis, especially for early osteoarthritis. Exercise has been shown to help reduce pain and control symptoms, to improve function and flexibility, especially as I mentioned early on in the disease. Muscle strengthening is good for pain relief, and aerobic exercises are helpful to maintain and to promote long-term functional gains. Certainly a healthy diet can contribute to weight loss, which decreases the stress on the joints of the lower extremity. Compliance with any exercise program is a concern. Studies show that both supervised classes, supervised therapy, and a home exercise program promote the best results. Any exercise program needs to be sustained over time. Certainly gains are lost over time once that program is stopped. Any gain that may have been achieved is certainly lost within 3 to 6 months of the time the program is stopped. Bracing for knees and orthotics for feet are very popular non-operative modalities. Their primary goal is to improve function by reducing symptoms, and the ideal candidate has mild to moderate osteoarthritis, wishes to maintain a healthy and active lifestyle, and is looking to delay or avoid major surgical procedures. Non-steroidal anti-inflammatory medications are probably the most commonly prescribed medications in the United States. They go by lots of different names, from over-the-counter Advil and Aleve to prescription medications from Mobic and naproxen to the COX-2 inhibitors, which only include Celebrex today. They are mild analgesics, and they also have an anti-inflammatory effect. Their big negative is that they have GI side effects. I always tell my patients to take them with food. GI side effects are reported in about 2 to 4% of individuals who take the NSAIDs. The COX-2 inhibitors, of which we only have Celebrex left today, were designed to address the GI symptoms, and they're thought to have them. So about 1% of people who take Celebrex still develop GI problems. They still need to be taken with some caution. Ice is a very effective local anti-inflammatory. It also has an anesthetic effect. I do recommend ice and not heat for my patients with osteoarthritis of the knee. It's to be applied in a 20 minutes on, 20 minutes off modality. Tylenol is a mild analgesic. It doesn't have the anti-inflammatory effects of the non-steroidals. However, it also does not have the same drug interactions. Narcotics can be effective for short-term pain management, but they need to be used with some caution. Anybody with a chronic condition, they have difficulty with constipation, with tolerance, and with addiction. Injection therapy comes in two major types for the knees. There are cortisone injections, which are local injections into the knee joint. They're local and very powerful anti-inflammatories. They're good for painful flares. Cortisone does have dose-dependent side effects. It can weaken the joints. It needs to be used with some caution and can only be repeated, usually about 3 to 4 times in about a year's time. What are very popular these days are the high hyaluronic acid injections. Those are literally injectable lubricants. They come in a number of different brand names. Synvisc is probably the most popular and the best known, but there's also Supartz. There's Orthovisc, Euflexa, just to name a few. There's Hyalgan as well. They were historically series of 5 injections. Some are 3. Synvisc is just a one-shot. They can be repeated at 6-month intervals, and they're literally injectable lubricants, or harvested form of the fluid that normally nourishes and bathes the joint cartilage. Very effective in some individuals. People report that they do tend to lose their effectiveness over time. We don't know whether that's due to decreased effectiveness of the medication or advancement of the disease process. So surgical management is indicated for those individuals who fail to respond to reasonable courses of the non-operative treatments. I'm going to mention 4 surgical procedures today. There are others, but these are probably the most popular for any arthritic knee, and they include arthroscopy, high tibial osteotomy, a unicompartmental knee replacement, which is literally a half of a knee replacement, and a total knee replacement. Arthroscopy is a simple operation, been around for quite some time now. It's got many advantages. It's safe. It's relatively effective. It's outpatient. We actually do it right upstairs here in this building. There is not much of a recovery. There's a quick and usually a relatively straightforward rehabilitation. However, its role is somewhat controversial in the treatment of an arthritic knee. Most people report at least some initial benefit, about 50 to 75% of people. And what we're talking about is literally what we call an arthroscopic debridement, which means cleaning up the joint through 2 little stab incisions, addressing any kind of torn or loose cartilage, and literally running some water through to bathe the joint surfaces. Despite the initial benefit, only about 44% report any long-term benefit at 6 to 9 months, and 15% of people with an arthritic knee who have an arthroscopy go on to a knee replacement within 1 year of that procedure. Recently, there have been a number of well-published and well-known studies that show that the results of any arthroscopic procedure in the face of arthritis may be minimal, and this may be even due to a placebo effect. There was a very widely quoted study by Mosley from the Houston VA, which was in the New England Journal of Medicine, and made it to the front page of the New York Times, where he looked at 180 veterans and he ran with arthritic knees, and he randomized them to 2 groups, only one of whom had the actual operation. So the other had a sham operation where the stabs were made, but they didn't undergo the surgery. And unfortunately, he didn't show much difference in terms of pain relief and functional outcomes between those 2 groups. Despite this and several other studies, there probably is a role for arthroscopy for an arthritic knee. Those individuals with mechanical complaints, with giving out, locking, buckling, clicking, with what are called unstable meniscal tears, probably do derive some benefit from the arthroscopic surgery. It's difficult to determine exactly who those individuals are. MRIs, which are the modality we generally use to diagnose meniscal tears, are somewhat unreliable in the face of osteoarthritis, especially advanced osteoarthritis, because most of those patients will show a meniscal tear on their MRI. So clearly, successful results from an arthroscopic debridement for an arthritic knee require very careful patient selection and frank counseling that the results may be limited, may deteriorate over time, and that individual may ultimately require a total knee replacement. High tibial osteotomy is a procedure that was very popular in the 60s, 70s, and even the 80s, somewhat fallen out of favor recently. It's an operation where literally the bone is cut. Sometimes a wedge is taken out, and then that bone is fixed, either with a plate or some kind of fixator. The primary advantage to a high tibial osteotomy is that it preserves the native knee joint. So it doesn't violate the joint. What you're doing is literally shifting the weight-bearing axis of that extremity away from the more diseased part of the knee to a relatively better preserved part of the knee. It's good for high-demand individuals, laborers, people who participate in high-demand sports, heavier people. Its results clearly deteriorate over time, so it should not be looked at as a definitive procedure, but more likely as a procedure that will delay the inevitable knee replacement in these individuals. To a certain extent, it's fallen out of favor because of better results that we have today with knee replacement surgery and expanding indications. Additionally, the results of a knee replacement done after a high tibial osteotomy are not as good as those done on a primary or native knee. A unicondylar or unicompartmental knee replacement is an attractive option. It was very popular again in the 70s and 80s. It fell out of favor with the excellent results that were reported at around that time for total knee replacement surgery. However, there has been a resurgence of interest. The knee is literally divided into three compartments: an inside or medial compartment, an outside or lateral compartment, and a compartment behind the kneecap. And this is an operation where literally only one of those compartments is resurfaced. It's thought that about 20% of patients with arthritic knees have isolated single compartment disease. Some of the advantages of a unicompartmental knee replacement are that it preserves the ligaments, especially the cruciate ligaments, inside the knee joint, which may give that individual a more normal or more natural feel for their joint. In a total knee replacement, those ligaments are generally sacrificed, and the concern is that that then doesn't feel like that individual's own knee. Unicompartmental knee replacements have had a resurgence in popularity recently with refined techniques, with refined instrumentation, implants, rehabilitation techniques, and with a renewed interest in less invasive types of procedures. The results likely and probably do deteriorate over time, primarily as the opposite compartment becomes arthritic, and that individual becomes symptomatic again. And most unicompartmental knee replacements over time do need to be converted to a total knee replacement. And finally, total knee replacements. Recent studies have reported excellent long-term and improving results with total knee replacements, again due to improvements in operative technique, instrumentation, rehab protocols, implant design. It's historically been considered a final option. Most of our studies look at knee replacements in individuals who are greater than 60 years of age, because historically that was sort of considered a little bit of a cutoff, although more recently more and more excellent and long-term results have been reported in knee replacement surgery in younger and healthier and more active individuals, more high-demand individuals. The results in that age group have recently been shown to be as excellent as those in a more elderly age group. Finally, return to sport after a knee replacement is a very controversial topic. Studies show that about 65% of people report that they're able to return to the sports that they would like to return to, but most report they do so at both a lower frequency and a lower level of intensity. Reasons for this are thought to be those people may be looking to protect the knee as opposed to mechanically not being able to tolerate the impact exercise. However, we do have a number of studies that show, one study shows that 12% of people ignored advice in terms of impact versus non-impact exercise, and that group of 12% had no increased incidence of mechanical loosening or implant failure over long term. So we have more and more studies that report that knee replacements may be able to tolerate heavier and more demanding impact exercise over time. Historically, the American Academy of Orthopedic Surgeons has advised against impact exercise, after a total knee replacement, although there is some controversy regarding that statement, and it's currently being reevaluated. And of course, everybody remembers Bo Jackson, who did have a hip replacement and went back to play both professional baseball and professional football, although probably not at the same level as he did before his hip replacement. So in summary, the treatment of an arthritic knee in a younger, more active patient remains a challenge. Non-operative treatment is effective in many people. It helps control symptoms, helps that individual remain more healthy and active, although it probably does not alter the natural history of the disease process, which likely is progression. So the treatment should be based on symptoms and expectations for that individual over the long term. Thank you.